So our patient is a 44-year-old male from Kollam who is a construction labor manager. He presented with complaints of swelling of the umbilical region since 3 months. And he noticed the swelling since 3 months, which was insidious in onset and progressing in size from about 2 centimeters to a present size of 4 centimeters. It was painless in nature, reduced on lying down and after ascitic fluid tapping. He doesn't give any history of vomiting, pain, nausea, or reduced appetite. Coming to his past history, he gives history of diabetes since 3 years. He's on metformin, 500 mg BD, and he gives history of significant weight loss since 9 months. He's also a documented case of chronic liver disease with portal hypertension, diagnosed 9 months ago, and the etiology being ethanol. And the index presentation was in June 2022, where he came with complaints of breathlessness, orthopnea, dyspnea on exertion with MMRC grade 3 for 1 week associated with breathlessness, and after tapping, he was feeling better. And he also gives history of similar episodes since then, and he required multiple tappings. And the last tapping was done in this year of January on 20th. He doesn't give any history of decreased urine output, altered sensorium, hematemesis or dark colored stools, no history of daytime sleepiness, facial puffiness or generalized itching, no history of tattooing, drug abuse, body piercings, no history of fever, no history of suggestive of bronchial asthma, coronary artery disease, CKD or thyroid dysfunction. As well, there is no history of any previous surgeries. Coming to his personal history, he has a mixed diet, regular bowel and bladder habits, normal sleep pattern. He has a history of chronic ethanol consumption since 20 years, more than 180 ml daily, and practiced abstinence since 9 months. He also gives history of cigarette smoking for 10 years, now abstained since 9 months. There is no history of any allergic reactions, no history of any family history, and he is a construction labor manager by profession. Coming to his treatment history, he is on tap furosemide 40 mg BD, and on tap spironolactone 100 mg BD, on syrup lactulose 30 ml BD, tap rifaximin 400 mg BD, tap pantoprazole 40 mg OD, tap ursodeoxycholic acid 300 mg BD, and tap metformin 500 mg BD.
General physical examination. The patient was moderately built and nourished, conscious and oriented to time, place, and person. He weighed about 70 kilograms at a height of 172 centimeters, amounting to a BMI of 23.6 kilogram per meter square. He was afebrile on touch. Vital examination. Heart rate of 80 beats per minute, measured on the right radial artery. The regular rhythm, normal volume and character. No vessel wall thickening. All peripheral pulses were palpable. He had a blood pressure of 100 over 70 mmHg, measured on the left arm in the sitting position. Respiratory rate was 26 cycles per minute, abdominothoracic type. He also had icterus present, as well as gynecomastia. However, no signs of pallor, cyanosis, clubbing, koilonychia, lymphadenopathy or edema were present, with no evidence of spider nevi, palmar erythema or asterixis. No distended neck veins were seen. Airway assessment, no obvious facial deformity. He had a mouth opening of 3 finger breadth. No restriction of neck movements. Thyromental distance was more than 3 finger breadth. With a Mallampati score of 2. No loose teeth or dentures. Temporomandibular joint movement was adequate. On local examination of the swelling, inspection, the swelling over the umbilical area was of approximately 4 into 4 centimeter size with an everted umbilicus. Oval in shape, reduces on lying down and aggravates on coughing. On palpation, there was a reducible and expansive impulse on coughing. Tenderness was present over the swelling. No pulsations were felt with no local rise of temperature. It was dull, note was felt on percussion and no bruit heard on auscultation. Systemic examination per abdomen. The patient was found sitting propped up on 2 pillows with arms to the side. On inspection, there was a generalized distension of the abdomen with the umbilicus everted. Bilateral flanks appeared full, and the skin over the abdomen appeared normal with an umbilical hernia present. No dilated veins, visible pulsations, caput medusae, or previous surgical scars were seen. On palpation, there was no local rise of temperature. Tenderness was present over the hernial site. There was a soft reducible hernia of 4 into 4 centimeter size, which was palpable. The liver and spleen were not palpable. No guarding rigidity was seen. Per rectal examination was not done. Percussion, liver dullness was percussed over the right 6th intercostal space on the mid-clavicular line. Dullness was percussed over the dependent areas. Fluid thrill and shifting dullness were elicited. No bowel sounds were heard. No arterial bruit or venous hum were heard on auscultation. Examination of other systems.
Just
This-
1 second. Anything remarkable in systemic examination for this particular patient?
Louder
Loud.
into the mic.
So far,
Any-
he has
anything-
evidence of process ascites on systemic.
No, systemic examination is okay, normal.
Further on? Yes, sir.
There's no positive findings or anything.
No, sir.
Okay, can you summarize the case?
He's a 44-year-old male, known case of type 2 diabetes on treatment with decompensated chronic liver disease and refractory ascites, presented with swelling over the umbilical region, likely an umbilical hernia for further evaluation and match.
Okay, why do you say it is
Keep the mic
decompensated?
with
You
you.
can sit,
No, keep the mic with you.
or you have told already, just for the records, anything positive in history you particularly elicit when you have a patient with CLD coming for your pre-anesthesia checkup?
So we will try and assess his history of, try and find the etiology through the history.
Sure.
So the history of, if most common cause, one of the common causes would be ethanol consumption. So the history of ethanol consumption, the duration,
Great.
Yeah.
Then
history of chronic, any other reason for etiology would be chronic hepatitis B or hepatitis C. So if history of previous transfusions, illicit drug use,
fair enough. Etiology, I agree. What else? Anything? Any?
of decompensation in the
Sure,
form of
okay, good.
upper GI bleed, hematemesis,
Sure.
melena,
Yeah.
ascites. We could also ask for history of jaundice.
Okay.
And
We'll also ask for some infection history of any infection happening. So you just summarize the case. That is, this is a CLD patient, decompensated, with history of diabetes mellitus coming for he has had
elective
umbilical
umbilical hernia
Is it
repair.
obstructed or not?
No, sir. This was
Okay.
not obstructed.
So do you want to further investigate the patient? How do you further assess the patient by you want to do any investigations? Because he has come for the surgery, isn't it?
So on blood work,
You have on the slide. Okay, you can put up the slide. Then.
Make sure you're louder. Ruchi.
these are the patient's investigations on presentation.
Read it out.
With the HB of 10.8, counts at 8,600, platelets of 2,14,000, sodium at 128, potassium 3.7 millimoles, urea was 17.5, creatinine was 0.69, a total bilirubin of 3.56 milligram per deciliter. The other LFTs remained within normal range. INR, however, was elevated at 23 for a control of 14 seconds with an INR of 1.5. The CRP
Anything
was
worrying in this panel of investigations for you? Worrying.
You said the rest of the investigations are normal. Are the enzymes normal? The transaminases? They are elevated. Okay.
And anything you feel is abnormal or you worrying for you in this panel of investigations, which you
What amongst these is worrisome to you as an anesthetist if he comes for surgery and anesthesia?
Sir, this patient has a borderline coagulation profile. So with an INR of 1.5 and bilirubin is
Is
around,
it called borderline?
it's elevated. Ma'am.
Elevated. I don't think it's borderline.
Okay. And what about sodium? Are you happy with the sodium?
Sodium, it's an expected value, ma'am, sir, because the patients who have a underlying CLD are prone to have a decreased sodium.
What's the reason?
Because the patient who is a non-CLD would have a increased splanchnic vasodilatation, which would trigger the RAS mechanism to compensate for the volume, to restore the blood volume. So there is secretion of ADH, which is antidiuretic hormone, which results in a water reabsorption, and there is also secretion of aldosterone, which causes sodium reabsorption. So when compared to the water reabsorption, the sodium reabsorption is much less. That is, so there is a dilutional hyponatremia which is developed in the case of CLD.
Okay, that's fine. In this patient, particularly as refractory ascites also, there's a more
Yes.
can contribute also to the dyselectrolemia and fluid manage abnormality. So, any further investigations you want to do? How old is this patient?
He's 44-year-old.
Okay, you want to do anything further?
I would like to do an ECG an echo.
What's any particular reason he's a 44-year-old guy, perhaps only diabetic, but you
This-
still want an echo? Any
Yes.
particular reason?
This patient is a diabetic as well as a non-CLD. So this patient is prone to have a systolic and diastolic functions, the dysfunction of the
Yeah,
heart.
good.
So by doing an ECG, we can try to rule out any right ventricular hypertrophy, or in case of we could look for
Right
a QT
ventricular
prolongation.
hypertrophy for is any. Why do you suspect right ventricular
So
hypertrophy?
patient who has, they are known to have an elevated pulmonary artery hypertension. So those patients who are prone to have that would have a right
Yeah.
ventricular
So
hypertrophy.
is that a very common finding? If I ask you what are the ECG changes you would find in a patient with chronic liver disease, you need to list them out. So, and right ventricular hypertrophy can be a manifestation. It's rather uncommon. Your patient may have it. It's not common. So what are the other things you would find besides the right ventricular hypertrophy? To
patient
say
would-
that first would be inappropriate.
The patient would have a QT prolongation, which would be more than 440 milliseconds. Would have a right bundle branch block, maybe.
Okay, fine.
So things like even a bradycardia, they have a chronotropic incompetence, right? Then evidence of prolonged conduction as a QT prolongation. Okay. Then any other associated ischemic changes, ECG manifestations of dyselectrolytemia, which is essentially hypokalemia, if there is.
Okay, an echo
So,
just to corroborate your whatever findings you expect.
What would you find in the echo of a patient with liver disease?
Ma'am, there are, since this patient is a known case of CLD and has a history of type 2 diabetes, there is a possibility that he could have silent myocardial ischemia secondary to CAD. We could have regional wall motion abnormalities resulting in a reduced EF as well. Diastolic dysfunction is more common in patients with CLD, depending on the grading. It could be classified as grade 1, 2, or 3, depending on impaired relaxation, pseudonormalization.
Just finished your cardiac postings. Okay,
Okay.
go on. It's correct. Go on.
So you justified to have an echo as well. Anything further? Any further
What are
investigation?
the other changes you would find on an echo?
Concentric,
You said diastolic dysfunction. Anything else?
reduced LV function, reduced contractilities.
That you said was associated with ischemia. What are the other changes that you would find? Any chamber dilatation that he was talking about?
Right atrial,
Right
right
atrial?
ventricular chamber dilatations.
Why is that?
Secondary to the increased load on the right side of the heart.
Increased the hypervolemia. So essentially reflection of hyperdynamic
dynamic
circulation. Is there any other manifestation of a hyperdynamic circulation you can see on an echo? Can you look at an LV outflow gradient? Yeah? Okay.
And also evidence of any cardiomyopathy. That's also very common. That also can happen in CLD patients. So anything further? You've done echo as well. Anything further? Further investigations?
We can do a chest X-ray to rule out any pleural effusion, or there's a risk of hepatic hydrothorax.
Okay. Fine.
Can you quantify any shunts by just an echo? Or at least assess if there are shunts? Are there any tests that can be used to? There are pulmonary arteriovenous dilatations, right? So what test is done along with the transthoracic echo for that?
So there is a bubble echo that is being done.
Contrast echo or a bubble echo. Okay.
What gives you information about what information does bubble contrast gives you? Why you suspect? If you want to do a bubble echo, what is your patient should have? Hypoxia. Roma's should be less than 95. So then only, or even less. So then you suspect patient having peripulmonary syndrome. Then you do a bubble contrast echo to confirm it. And if is there any treatment option?
I would probably disagree with you, Dr. Kishore, because almost 70-80% of patients presenting for transplant with a normal saturation end up having a positive bubble echo. But it is not significant. So you can document a shunting, But if the PaO2 is normal, obviously it's not hepatopulmonary. But there is shunting despite not having a hepatopulmonary syndrome.
So you've done the investigations, and how do you quantify the risk in these patients, CLD patients? How do you quantify? You all you have got the investigations, and
There are two commonly used scales. One is the scoring systems. One is the child pug score, in which we classify patients based on points. So, or depending on 5 major criteria. One is bilirubin, in which if the patient has an bilirubin less than 2, between 2 and 3, and more than 3 milligram per deciliter, they're given a score of 1, 2, or 3. Albumin in the same range, above 3.5 grams per deciliter, between 2.8 to 3.5, and less than 2.8 grams per deciliter are again classified with scores of 1, 2, and 3. Ascites, if none is present, if it's controlled and if it's uncontrolled, is classified as 1, 2, and 3. Encephalopathy, with a grading of no encephalopathy, is scored as 1. Grade 1 or 2 encephalopathy is scored as 2 points, and more, 3 or 4 is
So
above that.
how do you?
At the end of these, and the fifth is INR. So based on these 5 points, we classify the patient and as class A, B, or C, depending if they score between 5 to 6 points, it's class A. 7 to 9 is B, and above 9 is C. The other is MELD, which is the model.
Is there any deficiencies in CTP scoring systems?
Yes, sir, it's vague. It's also arbitrary, and some of the compared to MELD, which uses more objective values.
See, this is
Difference in a MELD versus a PU. What is the variable introduced in the MELD which is not seen in
creatinine.
child?
yes, CTP scoring doesn't take into considerations of
Renal
other aspects of
functions.
the patients as well. Then ascites and encephalopathy are sort of subjective assessment. Then the values of bilirubin, anything above 3, if 3 or 10 makes a lot of difference. So it doesn't consider the value of 10 or so. So what's the next scoring?
The other is the model for end-stage liver disease. That is based on a formula.
Okay,
You don't
just
have
tell
to remember the
factors, just
formula.
factors.
I use a
factors
calculator.
Are, it uses a logarithmic value of creatinine, INR, and bilirubin with a constant of 6 point.
Okay, fine. And how do you tell the patient if this patient in which
The
kind, what the risk?
mortality risk associated comes with if a patient is classified as child A, there is a 10% risk of mortality associated with an elective procedure. Child B comes at 30%, and child C comes at 80% of mortality. So
How much?
80,
Is it
75
so
to 80,
recently
it's
they have
come
an
down.
update? The risks have come down, isn't it, ma'am?
They've come
They've
down,
come down
but even
drastically,
I'm
but-
clueless as to what the figures should be.
It's around
They
2.
have come down, and it's
Because-
completely varies with the experience of the center.
They have sort of said it's around 2% for A and
Child
12% for B and C. Okay, and MEL scoring, where do you cut off? How much score?
Less than 10, 10 to 14, and above 14.
Okay.
Corresponds
Above
to
15 means it's quite higher risky. Any further optimization need for this particular patient in any aspect? Suppose you have if I say the platelet count is 48,000 and the INR is 1.7, that's what we most usually find when these patients come across. What would your take on that?
Sir, this patient is already on a process of ongoing altered coagulation. So we would like to do a point of care testing, which would be a TEG or a ROTEM.
And what do you expect? What does the coagulation system, what happens to the coagulation system in CLD patient?
In a setting of CLD, both the clotting factors as well as the anticoagulant factors would decrease its production. So there will be a altered coagulation profile, which
Simple term, simple. Just INR. Why is INR high in these patients?
What does the liver normally manufacture, which is deficient? Say, Mike.
Please use the
all
mic.
factors except for factor 8.
Okay, that's
so
vitamin
the
K
intrinsic-
dependent factors.
2, 7, 9, and 10.
So that's why
The-
reason why INR is high.
yes.
And you said something else about the coagulation.
yes, sir, both the clotting factors as well as the anticoagulant factors are being decreased, synthesis is being decreased. So there is a rebalanced homeostasis is what they call it is. So because of that, there can be increased risk of clotting as well as increased risk of bleeding. So it is better to do a dynamic test rather than doing.
Okay, so there is a dynamic rebalancing of the clotting system. Even though the INR is high, there is 1 milligram factors increase, so they need not bleed with this value of iron. Okay. So why the platelets are low? What's the reason for low platelets in this patient?
Thrombocytopenia.
Decreased thrombopoietin production from the liver. That's the primary cause. There's also consumption losses, decreased bone marrow suppression,
Consumption losses where?
DIC. If it's
Consumptive coagulopathy. Is that what you're trying to say?
yes, ma'am.
What are the other causes for low platelets?
Functionally altered.
Are they functionally altered? What happens to the spleen in liver disease?
Splenomegaly and sequestration of platelets in the
Does it sequester or did it lyse them? Platelet destruction. All formed cell elements are destroyed in the spleen, right? That is the reason why you have anemia, low WBCs as well as platelets. There is a destruction.
Portal hypertension is the primary reason for all these things happening. So, okay, carry on. So, you as I said, 48,000 and 1.7. So, what do we do? What would you do before surgery? Do you want to do anything before surgery, or what is the recommendation?
So this patient, we would preferably want a hemoglobin of at least 8, above 8. And
What I'm asking this,
yeah, and
He's
the
saying the
platelets of-
patient has a platelet of 48,000 and INR is 1.7. He's scheduled for an hernia. You have 8 minutes, so you need anesthesia time. What are the cutoff values before you say he's fit for surgery? The question he's trying to ask you is, are you going to accept, are you going to test, or are you going to transfuse?
we would need a platelets of at least 50,000 and above, and an
Okay.
INR of less than 1.5. So we would like to transfuse platelets prior to
Is there any harm in transfusion?
the risk of
I mean, it's very easy to say, I'll give, my platelet should be above 50. I won't give one, I'll give two, or I'll give one SDP. So my next question is there harm in overtransfusion?
patients tend to have they can be posted later for transplants, and there can be a risk of allergen.
That is another one complication. Anything else? What happens to the volume when you
And there
transfuse?
is already a fluid overloaded hyperdynamic circulation with splanchnic
So what happens if I give 2 FFPs?
So we can also
Joel? So if the portal pressures increase, you have an increased risk of bleeding from the dilated varices. So you need
said
to
something
remember that.
about point of test. So do you want to elaborate
Would you
on
like
that?
to test these values by doing a point of care testing?
so in tech we have the R value and the K value, which is a reaction.
So if he's saying platelets are low and INR is high, so what do you look for in the TEG?
we look for the maximum amplitude,
What does that tell you about?
the clot strength, ma'am.
Yeah, but what point of coagulation does it tell you about? If you have the maximum amplitude decrease, what does it imply? It's hypocoagulable, but which component? Like R is something, angle is something, and maximum amplitude is something. Mike.
R shows clotting factor
Yeah.
deficiency.
And maximum amplitude?
Platelets.
Platelets and fibrinogen actually, but then you counter check with alpha.
So if your tech or rotom is okay, would you go ahead? Can we go ahead with the surgery? Rotom and this thing may not be available in many other places. So
Right. What he's saying is right. You may not always have a TEG or rotum. But if you had values of 48 platelets and an INR 1.7 and the patient is posted tomorrow, what would you like to do? Would you accept? Would you transfuse? Or would you say, I'll accept and see and then transfuse after arranging products?
We would take up the patient and arrange the products.
yeah, good. Because you yourself said this patient may not bleed because these values may not be. So that's okay. You can always if you have a tag, you can do tag and may sit happily. Otherwise, you can take the risk and go ahead. So what are your concerns in anesthetizing these patients? What are the anesthetic concerns for you?
So
when
the
you are
main
about anesthesia?
concern would be any further decompensation that can happen to this patient depending on the type of anesthesia we would like to give. And as this patient is in an ongoing coagulopathy, there would be always a risk of bleeding at any point of the time. So we would want to minimize the bleeding, and as well there is there is a risk of ascites, and the patient could be on full stomach. So we would want the patient to have a pre-induction Riles tube to be placed, we would suggest that. If not, we would also
I
need.
think that would be dangerous.
What
That
does
would be dangerous unless you have evidence that the bowel is involved, because you may not have evaluated the portal hypertension. I think Anu is not here, otherwise she would have something to say. Okay, so I think Riles tube we leave out. You said he's not obstructed. Let's not get into Riles tube. He's full stomach. So you may want to do a rapid sequence induction. Then
And upon opening in the perioperative period, there can be loss of the ascitic fluid. So we would like to arrange for albumin and transfuse albumin if required. And another concern would be there would be increased risk of arrhythmia due to dyselectrolemia. And we could also would like to maintain a urine output, because patient would have an underlying renal dysfunction in a setting of CLD. And post-op analgesia would also be a concern.
you wouldn't be worried about any drug issues?
We would also be concerned about the quantity.
Drugs you use?
metabolism of
Metabolism
drugs, is it
and,
affected in liver disease?
What way the drugs are affected? Just short. Or
So opioids, benzodiazepines, even
No, he's asking
even
you
IV
how,
induction.
in
How-
what
what
point
are the
is the
points
drug
the drugs
metabolism affected?
Most of them are
You have a
affected
drug
in-
being given, administered, absorbed, bound, transported,
so many
hepatocyte,
things. So basically, what
Phase
are the
one.
phase 1, phase 2, phase 3. So
Phase
you
one.
need to say where all, which drugs, if you can. Otherwise, broadly say what is your choice of induction agents and why. How, supposing you had to give general answer. Now, you haven't said your choice of anesthesia. What would be your choice for a patient with MEL sodium of 18? 23. What is his score?
23.
23, which is a child C, right? And he's come with an umbilical hernia. So today, what would be the choice of anesthesia for this patient for an unobstructed umbilical hernia?
Ma'am, we can go ahead with an ultrasound guided peripheral nerve block. We would choose a bilateral rectus sheath block.
Okay, I would second that. Supposing he had to have GA, let's say that there was
Surgeon
bowel involved.
What you do a open or lap? Device.
So
This would be open, right? He has ascites. They wouldn't probably want to do a lap umbilical hernia for a child C patient. So let's stick to open in this case.
But if GA is now, what broadly affects the drugs when you give it to a chronic CLD
the
patient?
hepatic extraction ratio and the hepatic blood flow. So
Drug binding is normal?
no,
One
albumin.
is
It's a
metabolism is, as you said, phase 2, phase 1 metabolism is affected.
drug affected.
Second is the volume distribution is quite high in these patients, so that can affect the effect
is
of the
good.
drug. Third is protein binding. Albumin is low, so albumin bound drugs, free drugs will be more. The other glycoprotein drugs, if it is high, that unbound drugs will be less. So those are the factors which affects you in choosing the drug and what dosing, what intervals. Okay. So what will be a choice if Madam said if they want a GA? What would be your
Supposing there is bowel in it, let's not say about lap, but let's say instead of just omentum, he has a piece of bowel and by ultrasound, the viability is uncertain. So it becomes a obstructed irreducible hernia for an emergency laparotomy in a child C. How would you induce? What are your concerns? What do you keep ready? How do you induce?
Ma'am, we have blood products arranged. We'll start with
okay? Fine.
adequate. If we have adequate NPO status, we can also start with awake Riles tube. Or we can use
Okay,
that
the reason I contested that was these patients have portal hypertension and very large varices. So you can actually injure a varix enough to cancel the surgery or cause the death of the patient by a Riles tube, which is why in this particular instance of full stomach, I would not recommend Riles tube or at least exercise caution. It cannot be inserted by a trainee.
an invasive arterial line prior to induction of anesthesia. We would go ahead with rapid
Your plan of anesthesia would be GA.
GA with controlled ventilation,
with-
endotracheal intubation,
Rapid
Okay, fine.
sequence induction.
Okay,
yeah,
rapid
sequence
Okay.
induction. sir.
So what drugs you use for induction? What for maintenance? Okay.
So for
what for
induction-
pain relief?
So for induction, we would go ahead with ketamine and 2 mg per kg, or along with that, we can go with
Ketamine.
etomidate.
So your choice of induction agents would be based upon the hemodynamics.
Yes.
He's
Okay.
otherwise
Ketamine,
okay.
if the patient is unsafe. What made you say ketamine?
Ma'am, it's an excellent analgesic, and
No,
also
why do
that,
I choose ketamine? I normally give propofol. Why am I saying ketamine for this
we
patient?
also want to keep our pressures on the higher side and prevent any
Higher
hypertension.
side?
He's
Or
otherwise
normal?
stable. He's
We-
stable, no?
yeah, yes.
Hemodynamic stable.
We-
So why do you want to use a?
So his
Use
starting BP
etomidate.
Yes,
Can you?
yes, ma'am. It's more cardio stable, so both
Okay, I
What
agree.
was his blood pressure?
170 to begin with, ma'am.
Why do you think it's 170? Is that abnormal for a CLD?
No, ma'am. They generally have lower pressure.
Okay, so you're not worried about hemodynamics. So I wouldn't put ketamine as my first choice. Okay.
Right.
Etomidate.
Okay, so you use intermediate and RSI, rapid sequence signal. What drugs you use?
Succinylcholine, sir, 2 mg per kg.
Are you worried about anything about succinyl methonium in this patient?
There's delayed, the action can be slightly affected because of the pseudocholinesterase levels. But
Or could you use any other non-depolarizing agents?
so cisatracurium,
No, if you wanted to do a rapid
rapid
sequence, he
sequence.
wants to ask you what is the alternative to succinylmethonium.
rocuronium, but
Yeah, but
they
are you worried about rocuronium?
yes, sir.
That is also known to cause hepatic. It's a hepatic metabolic drug, so the metabolism of rocuronium could also be affected.
Okay, but you have something new now in the.
So gamma tax.
Do you have that? Okay, fine. That's fair enough. So you use succinylmethonium, keeping in mind that action may be prolonged. Okay, what for maintenance
So
and pain?
Oxygen, nitrous,
oxygen, air, and
inhalation.
sevoflurane. Inhalational method of maintenance of anesthesia.
Okay.
We could also supplement with opioids now.
What specific?
Fentanyl over
Why
morphine.
fentanyl? Why not morphine?
Morphine would again have a
If you give morphine, the pain will carry on for a long time, isn't it? So anyway, you just justify why you use fentanyl and why sevoflurane?
sevoflurane because the metabolism is about 5%. It's the least.
But isoflurane is much more less. It's only 0.2%.
It helps to preserve the hepatic arterial
Yeah,
buffer.
that's-
as well.
okay. But I think all of them will preserve the hepatic. Your concern should be maintaining the hepatic blood flow. So for further, okay, fine. So your pain relief
We could consider
for
20
intra pain
managers.
relief.
Intro?
Fentanyl you said. How much?
2 mics per kg, sir. We can titrate actually.
Anything else? Would you give paracetamol?
Yes, sir. Up to 2 grams per day can be given even in a patient with CLD. So IV paracetamol 1 gram or 15 mg per kg for him.
Okay. What all things you monitor apart from the routine things? Routine you love.
Peripheral line, arterial line?
Yes,
Sir, we could also use a BIS monitoring to titrate the.
Yeah, that's fine. Fair. Accepted. Would you be worried about temperature?
yes, sir. Hypothermia
And
can
So if
what
it is
about
a
urine output?
laparotomy, it's a major surgery. I think I would go for a central line as well.
And
ultrasound
urine
guided.
output?
So we'd like to intraoperatively measure the temperature, the urine output, the CVP trends.
Okay. Suppose the
consistent
urine
arterial
output
blood
tails during the surgery. It's not expected less than 0.5 or even some oliguria is there. Would you be worried or what would be the reasons? Your BP and everything, fluid status is okay.
It could be a decompensation of the liver.
You're standing in the OT, it's an exploratory laparotomy for bowel gangrene. Hour 2, you're seeing first half 50 ml, second half there's only 10 ml. The blood pressure was 100 to 70 to start with, and now it's showing 85 by 45. What will you do?
Transfuse albumin for
Straight albumin? What is happening? What do you think is happening?
kidney injuries.
Huh?
AKI.
So, ma'am, the fall in the mean BP will result in a
Yes,
loss of-
otherwise?
Other reason? Any other 2 reasons for?
What is, you were talking about the hepatic, the renal, this thing, and whatever aldosterone and extracellular fluid. What can happen?
renal vasoconstriction.
Yeah. And
Splanchnic extreme vasodilatation can happen under anesthesia as well. So you would need to, of course, be careful about the volume and start a vasopressor in this case. Then you can improve fluid by albumin if needed.
few words about HRS which happens in these patients. You know what is HRS? Okay. What are the types?
Sir, HRS is basically there's a development of
He's asked what are the types. Do you know the
there are
answer?
two types, HRS AKA and HRS non-AKA.
Okay. That's a
And-
good new nomenclature is like that.
Then
Okay.
It's more than 0.3 milligram per deciliter of creatinine within 48 hours, or more than 50% from the baseline within 7 days.
That's acute presentation HRS, HRS
AKA.
AKA.
HRS AKA.
And sort of a chronicity you call it HRS other one. Okay.
the low EG.
Okay, what about post-operative pain in these patients? How will you prescribe post-operative pain for this patient? Will you extubate? Okay, leave alone the obstructive part. Will you extubate?
So the-
Okay. What about post-operative pain? How will you prescribe?
So is their pain requirement the same as a normal population? Huh?
It'll be lesser.
It's much less. Okay. So describe how you would manage for a umbilical hernia.
Hernia repair.
One of the methods would continue to be a bilateral rectus sheath block.
Okay, that's fine. I
Another
agree.
could
Good.
be IV paracetamol. We can also
How much?
supplement,
How long?
15
Duration.
mg per kg.
Any- Okay, adult patient,
1 gram TID.
TID. Okay, fine.
In this patient, actually for CLD, up to 2 grams a day is allowed. So PD could be used. Along with that, we could consider using centrally acting non-opioid analgesic like nefopam.
Does Nefpam affect the kidney? Okay.
We could
Post-operative patient, what are you worried about post-op in these patients? Apart from pain. Pain is there, you have to address the pain. Then what will be looking?
I think pain would be
Monitoring.
the least of the things
Okay.
I would worry about. What are the other things that can possibly happen?
evidence of decompensation.
Yeah,
we
sure.
need to
So
look
what you'll be watching for any
if
development of encephalopathy?
a drop in urine output, if there's any rise in enzymes or deranged LFTs,
Okay.
if there can be any evidence of hematemesis or melena.
Okay. I mean, initial NCF is, and what test will give you that liver is failing? Anything? Any test? Blood test, which you have mentioned earlier. What's the
So, Dr.
What is the protein metabolism that the liver is involved in and which can be measured in liver disease?
Can look for ammonia
Marker.
levels.
Okay, fine. If there's a rising ammonia and undue rise in PTINR, you should be suspecting that there is decompensation liver is failing. Anything?
I think.
Okay, thank you. Very good. Good.
Thank you, sir.
Are there any questions from the audience? I'm not sure how much of it reached. Are there any questions, clarifications, or corrections?
I think she said the patient comes for repeated abdominocentesis because of ascites, right? Did you say about that?
What did you say?
Yes.
There's a history of repeated ascitic tapping.
Tapping, right? So then your albumin is normal. Is it because
2.8.
patient? No, 3 point something.
He's been
3.7.
supplemented with
Albumin
Yes, sir.
infusions were
Yes.
given.
He during this surgery also he was
No,
preoperative.
was that on your preoperative? Did you give that
No,
history?
ma'am. It was already being corrected.
That's
as
very
a-
important because otherwise we don't expect the albumin to be normal in these patients.
Must have been given as a correction for the
Exactly. So
ascites.
that has to come in the history. All right. And second thing is about your patient. When you did the ultrasound, did your patient have any shunts?
What shunts?
Any arteriovenous shunt, linorenal or whatever? You know, you have to look for it, right?
No, ma'am.
In the ultrasound.
We don't look.
You
for
don't.
it.
No.
No, it's just CT manifestation of.
So
AV
the
dilated,
point I
varices
want to
or
get
some-
across is in such a patient, supposing they identify shunts.
What shunts?
Any say linorenal shunt, which is naturally formed shunt,
It may have been picked up on a CT. I don't think it is
not on the
left to
ultrasound.
us. No.
Okay. So
We are not sharp enough to pick
What
up
is the
that.
relevance, madam? Even
no,
if they
if
find a
that is there, then the incidence of hepatic encephalopathy is very, very high in such patients. So that comes in as an earlier manifestation. And serum ammonium is the investigation you have to do in these cases.
It all depends on how bad the CLD is, isn't it?
That's what. It's only
how bad
those
the
bad
Yeah.
patients who end up with NCAF, you know.
Yeah, they're so bad that I was mentally imagining this patient, and it would have been like as I said, pain was the last thing I would have been worried about.
Yeah.
Thank you.
Thanks.